It is 12:02, and I know we have a lot to get covered. So, Luann and team, take it away.
Great. Thank you, Maitel. I'm Luann Kimker. I'm the VP of Clinical Innovation at Azara Healthcare, and I am joined today by my colleague, Molly Wack, who is a Client Success Coordinator. And also, we're going to have Megan Reynolds from the Chautauqua Center join for a part of our discussion today also. So today we're going to talk about the role of pharmacists in managing chronic conditions and how the tools and drives in CPCI can help you. You know, we want to make this exciting for you. Hopefully we've got some interesting information to share and some things for you to ponder and think about in your own centers. So please, you know, use the Q&A or chat box, whichever one is available to you. You'll be muted, but ask your questions as we go along. And Sophie and or Molly, if you're able to see them, anyone, feel free to pop in if the questions are appropriate, and we can take care of them. So as I said, we're going to be talking about the role of the clinical pharmacist. We're going to talk about screening tools for early identification. How do you identify those patients that you want to focus on? How do you manage that population? What tools can help you to do that? We'll talk a little bit about the program management piece. Probably not as much on that, but I think it weaves its way through. And we'll talk a little bit more about care effectiveness and quality improvement reporting and sort of what those differences are and what kind of things you're going to see in drives or CPCI very soon. So chronic conditions are challenging. This is the dashboard that is stock in drives. And I actually, instead of pulling for all of Chicane's, which is a very large number of patients, et cetera, I chose the 10 centers that are in the DCPC project just as a smaller subset. But you can see from looking at them that there's still decent amounts of opportunity, right? Diabetes with A1C greater than 9 or untested is at about 31%. Hypertension control, I mean, the good part is that the Healthy People 2030 goal is 61%. So these 10 centers clearly are above that at 65%. Statin therapy at 76.9, so that's patients who should be on a statin, and IVD and aspirin is 60.4%. So, you know, if you're wondering how you're doing on your chronic conditions and you haven't already, take a look at this dashboard. And what you'll be able to see is the trailing year results, the calendar year results, and the gaps. So if you want to know, again, this is 10 centers, so it's a big number. Yours should be smaller, but you can identify who are those patients who are not in control. Now, I put this up here because we're talking about chronic conditions and ways that we can improve their management. I also know that these are really hard measures to move sometimes. And we are just coming out of the pandemic where it's been even more difficult for you to be able to connect with your patients. But if you look at the trends over the years, and these are actually looking at, I'll make it a little bigger so you can see it. So in A1C, we're looking back 4 years. So we're looking at 2018 to 2021. And it's hard to look at trend lines because of the pandemic. But you can see we were doing much better and then not as well in between 2018 and 2019. When you look at statins, the statin use has definitely improved over time. And hypertension, controlling high blood pressure went up, and then looks like the pandemic is sort of what brought it down. So these are hard ones to look at, especially when you're looking at such large populations, and because they are reporting measures that are more for accountability, the way that patients drop in and out of these groups makes it hard to see improvement on the populations that you may have more focused interventions on. So I wanted to start after that little piece of asking you what you are doing or planning to do that is different in managing either your diabetes, your hypertension, or your elevated cholesterol patients. And so if you can go to menti.com, and Molly will probably put it in the chat for us. And the code is 2755-4848. And if you can just jot in a few words, that would be great.
Yeah, so I put in the chat the link you can use to enter your comments.
Thanks, Molly.
And Luann, you might want to go forward one and then back to get it cranking.
Say that again, Molly.
If you go forward a slide and then back, we might be able to see the results.
Gotcha. Don't be shy out there. This is that participation piece. I'm going to see if we get anything. If you're having trouble logging on or getting through, can you let us know in the chat?
I'm looking at the poll, and I think we are looking at a different question, actually. I'm seeing, do you have a clinical pharmacist at your center?
Ah, interesting. So you have the second question. So you can answer that one, and we'll have the results then when we get there. I'm going to move ahead, and then I bet that it will come back to this one. Let's see what happens. So in asking that question, there are a lot of different things and ways that you can think about managing these populations, and I'm sure that some of you have. But sometimes it does take trying something a different way. When I was doing this slide, what it made me think of was, the definition of insanity is doing the same thing and expecting different results. And sometimes I feel like that's where we might be. But there are plenty of innovative things out there that folks are doing. And so sharing those is great. Thinking about medication therapy management and the role of the clinical pharmacist in the care of patients with chronic conditions has been shown to have some really positive effects. And really what that means is that you're going to have a clinical pharmacist who's helping to identify and remedy medication-related problems, do some of that disease management education in support to what the provider or a care team is doing, be able to spend more time addressing medication adherence issues. Sometimes they have more data available to them or more readily available to them, depending on if you have a pharmacy in your center and that patient is using that pharmacy, but also can help them to consider other preventive health strategies. So you end up with this comprehensive med review and assessment, as well as the end, then a care plan that is shared with the primary care provider, and you have this very close working relationship in terms of the management of those patients. So now let's see what we get. Okay, so we have clinical pharmacist. Question, so we've got no, we don't have any plans to. We've got no, but we're looking to hire. Anybody else out there who actually has some? Yes, but not maximizing the role. And I'd be curious, and let me go, just gonna go back and see if our other slide is, I don't know if it activated or not. In comments, also as you're, responding to this, think about if you are not maximizing that role, or if you are looking to hire, what are your goals? What are you hoping to achieve when you do that? So I'm going to move ahead, but if those of you have not responded, please log in and give us your answer, because we'll go back and use this data to share with the whole presentation. So I want to do a shout out and thank you to some pharmacists throughout Chicanes. I've listed them here. We met with them a couple of months ago as we started preparing for this webinar to learn a little bit about what they were doing and how the role of the pharmacist was being used in their center. And what I can tell you is it was a great conversation first. And the kind of things that we learned were that, the current role of the pharmacist, some are doing MTM for targeted populations, mostly focusing on asthma, diabetes, and hypertension, and then some other random patients. And a lot of times they may be participating in rounds with the patients. Now, one of the things that we were interested in understanding is how did they identify their patients? And what we found is that there was a broad spectrum of how this was happening. There was one center that was using the PVP and looking at transitions of care, and they were really just sort of getting started with that. More than one were using EHR generated reports or registries based on specific patient criteria that someone had set up to them or would run and provide to them. There's still a significant number of provider-driven referrals. And then there was sort of these other ways that people were finding their patients, and that was based on payer-driven compliance reports, either the dose compliance letters or fill rates, and SureScripts fill rate information. What we heard, though, was that even though some of the work was similar, the processes and specifics were very varied. And I'm not sure that even for the ones that had very specific ways that they were getting that information, it seemed less programmatic or that they were working on those programs and building them out. But none of the groups, as we talked to them, had really focused on looking at the impact of their role and intervention on the patients that they were seeing. So really that return on investment. And I think that drives CPCI, that has the ability to be able to help folks look at that, evaluate what is the return on investment for having the clinical pharmacist, and therefore help you add that as you go forward. So they wanted, when asked, what they would really like, part of it was to be able to tag patients based on interventions to compare to a control. And then also, an app sort of showing information on patient progress. And we'll talk a little bit, it's not really an app, but we'll talk about how you can see progress, on particular patients going forward. So what are the barriers to using a clinical pharmacist? Because that would seem to make sense, right? And so there are two studies that actually happen to be involving federally qualified health centers. And the barriers that they identified were lack of collaborative practice agreements, provider buy-in, time, resources, and then lack of Medicare recognition as a provider, which really gets to how those services are billed for. And, on the pay spectrum scale, pharmacists, are probably closer aligned to a provider, but without a revenue stream associated with it. And so that's something that we need to definitely look at. So there were 2 studies, and I've got links to them in the references at the back. But really some cool things, and they were focused very differently. So the first one was actually about 7 health centers in Ohio. It was a multi-site prospective project that did a mix of qualitative and quantitative results, looking at the impact on A1C and hypertension, and I'll show you some slides on that in a little bit, but also the interviews around what were the things that were necessary to initiate and then be successful in sustaining that program. And this study was done 2014 to 18 and published in 2019. And then the second one really didn't focus on quality at all, which was sort of disappointing to me. But their primary focus was around payment and reimbursement. And, you know, sort of their rationale for not focusing on quality piece was there were already studies out there that were showing the impact they can have on quality. But because one of the barriers was around payment, they wanted to be able to take a look at that. And theirs was a retrospective observational cohort study that was also done with a large federally qualified health system in Indiana. And I think it is probably one of the largest in Indiana. And basically they had a center that was doing a cardiovascular clinic that was pharmacy run. And so they did some comparison between those visits that worked with a primary care provider, and then when the primary care provider did not work with a pharmacist, and showed that by billing, they were able to increase their level of coding based on the services provided jointly between the primary care doc and the pharmacist. So I think that's, you know, a really interesting way to think about things. Although, as they identified, it takes a little bit more work when you have to coordinate 2 people's schedules to be able to work together. And in the first study, the one done in Ohio, they really had said, we think it's more important to improve the quality, and we know that that can happen. And they were less worried about the cost associated with it or getting how they got their reimbursement. So it'd be nice to try to find that place that is sort of in the middle, because we know we need to be able to show the return on the efforts that we're putting forth and the staff that we're having. So what do you need to have a successful pharmacy integration? So I think what is true to most projects that we do in healthcare is identifying champions across the organization, at the C level, at the quality level, and in administration. So someone who's going to be behind you and help you move this forward in amongst all the many efforts that you have. The second piece was around aligning the benefits with the federally qualified health center quality care goals. So thinking about patient experience, your health outcomes, and the clinical quality measures. And then the next piece, which is the one that we like to focus on, obviously, is around creating a data plan. You need to be able to share that data in the team throughout the center. And you need to be able to do it from a physician perspective, the patient perspective, and then your health outcomes. And you want to be really clear up front that these are the things that you're looking to change, and then be able to show how you've made that change and that impact. And by sharing that data, you'll start to build those relationships, ask questions, and hopefully reduce some of the burden associated to providers on the care team, which is clearly a part of, you know, the HCCN efforts, as well as improve provider satisfaction and get better outcomes. So before we go into some of the specifics that DRVS has, I want to introduce Megan Reynolds, who's the Director of Pharmacy at the Chautauqua Center. She's been there about 3 years. And ask her a few questions and let her share sort of where they are in their journey to implement and utilize the role of the clinical pharmacist. So, Megan, are you able to unmute yourself?
Yep, I'm here.
Great. Megan, can you tell us just real quick a couple of snippets about your center and what your pharmacy program looks like right now?
Yes, so we're in kind of a unique situation with our pharmacy program. So like you said, I've been here 3 years, and the whole 3 years this has been kind of an evolving program. Up until very soon, we're going to be dispensing on-site for an in-house pharmacy. So I've kind of worked up to that this whole time that I've been here. And so in anticipation of having our own on-site pharmacy, we do have a contract with Evergreen Health Services up in Buffalo. So a 340B contract. So we currently are filling prescriptions for our patients. We are able to see how they're filling and their trends of filling with their fills at Evergreen. We're able to work with our providers to manage issues with patients maybe not picking up medications, with side effects, interactions, compliance, things like that. But we have, so again, in anticipation of being open here in the next couple months, we do have 2 other pharmacists on staff waiting to be able to dispense. So in anticipation, they've been just kind of working with the providers, trying to be those clinical pharmacists in the clinic at this time. So they've been able to assist with med recs and identifying issues with patients that are utilizing our contract pharmacy services. As far as tracking, do you want me to just kind of go down the list here?
Yeah, sorry, I muted myself. I was going to. Are there any particular patients that you really focus on, or populations that you see yourself focusing on more in the future?
Definitely the diabetic population. The asthma is one that we've been trying to focus on, the proper treatment of asthma diagnosis, patients with an asthma diagnosis in their charts. And then the hypertension. So hypertension, diabetes, and asthma are the 3 that we've kind of identified that this has been something that we've just started digging into with Azara since we've started this discussion here in the last month or 2. So those are the ones that we've identified at our center as areas of significant need for improvement. So we've been able to look at those and see where we need to track those patients.
Great. And how have you tracked them in the past?
We have not really tracked them very well. We have tracked them sort of through maybe by their fills with the pharmacy, through interactions with the providers, but it's not been a formal tracking process. It's more of as the patient is needed, has needed us, or the providers have needed us, we've been able to jump in and follow through with any current issues or things that have been more of a immediate need. And then we follow them through with their refills and their compliance. But otherwise, unless they're having compliance issues, we don't really follow them very well, which is why this really helps us to be able to see the patients that we need to be able to track and follow.
Great. It'll be interesting to see, and I don't think we really talked about this piece, but what is the frequency, or what are the criteria that drive continued follow-up or meeting with a particular patient?
So I think that would be, if they're not meeting the measures that they need to be meeting, a lot of the times the providers will come to one of the pharmacists and say, I've seen this patient 3 times in the last 6 months. Their A1C is not going anywhere. We've tried different meds. What can we do? And then,
Right.
you know, that's more of when the pharmacists are involved with tracking the patients, and the providers, when the providers are seeing a trend not going in the right direction, they'll
Right.
bring us on board. But otherwise, there's, you know, that's more so what we're doing now. But going forward, it would be more of keeping an eye on the cohorts that we would be able to create within Azara and track them appropriately.
Perfect. Are there any questions from the audience? And Megan, do you have anything else that you think would be valuable to share with your colleagues?
At this point, I'm still learning this program. I'm still learning, you know, where to find everything in Azara and how that benefits our patients. So I'm here to learn too. So I'm happy
Great.
that we are learning all of these new, well, for me, it's new ways to get into the different reporting mechanisms and being able to pull these cohorts and to pull the different patients that we can really track and to hopefully help with their outcomes. So I don't really have much more. Any questions I'm happy to answer, but I'm definitely here for learning as well.
Great. Well, thank you, Megan. You know, people are all very busy, and you know, Megan, we spent a little bit of time with Megan looking specifically at her program, and so that is one of the benefits when you help us out, is we try to help you out and figure those things too, as well as helping the larger group. So let's talk a little bit about population identification, because that sort of drives everything else. And I see we do have a question. Is there a point of care tool that providers can use to assess medication adherence if you don't have a pharmacist on site? I'm going to share at the end some new functionality that is coming for those centers who work with Health First. And so with some pharmacy data. So hopefully you're a Health First client, and we'll see where that goes. The key there is being able to link to payer information and fill rates and how you get that information. So feel free to ask add-on questions. We can come back to them at the end. So common elements to the medication therapy management models. This is from the study that was in Ohio, done in Ohio. And I think the piece that I want to highlight on here, at least for right now, but I think these are good for you to come back and look at, is around patient identification and eligibility criteria. So when you think about who the patients are, right, we get referrals that can come from the medical provider, which are less objective, and they may or may not remember what all the different criteria are that you've established. You've got a referral through your EHR. So some providers may be creating a referral so that the pharmacist can see them. One thing that I have heard throughout the country when we've talked about pharmacy stuff is it's hard to know who the pharmacists have seen, because they're not always billing and they are not always booking appointments. And so unless they're keeping some sort of spreadsheet of the patients that they've seen or a list, they don't have good ways to do that. They could be disconnected lists that are run from the EHR, but they're not able to track and follow those. And the last way for identification is sort of that EHR data mining, looking for specific criteria. And most of that is around uncontrolled conditions, which you can get sort of in the measure detail, or patients who are on multiple medications or polypharmacy. So in this study, those were the things that they looked at, which I don't think are uncommon to what most of you would be interested in. So in CPCI, there are multiple ways that you can get at this information. You can look at measure details and create cohorts around those populations. You can filter it down to specific criteria around diagnoses or social determinants. And I think that is another area where the pharmacist plays a huge role in identifying some of those social determinants that may not have been as obvious but impact their medication adherence. For those of you who have Azara risk, you're able to look at high-risk patients versus all of your patients when you need to focus down, registries, and cohorts. So cohorts, you can think of two ways. You can create a cohort of patients that you want to follow, and that would be when you do that through a registry. Or the measured detail, you know, patients who don't have an A1C that's in control. Or you can, if you know you have seen particular patients, each time you see a patient or once a week, you can add them to your cohort in drives and in CPCI. So I'll show you how to do that. So you can look at those patients who are not in control. You might also use some of our other measures that are out there around like hypertension medication intensification or ASCVD risk to focus on a particular population and try to make a difference there. The other way that you can do this is if you are booking appointments, if the pharmacist is booking an appointment when they see their patients, you would be able to filter by rendering provider and see all of the patients or do a count of encounters that pharmacist has completed for the time period. And so I have an example here. We were playing with Alex Danforth in Trillium, at Trillium, and created a couple of cohorts, again, depending on what you want to look at, right? So you can take the patients that you saw as a pharmacist in 2020 and then see how they are continuing to do in 2021, either by visits and or performance on measures. You might want to just look at all their active patients, right? Like who do you define active? Like seen in the last year or seen in a longer time period? Or you might just look at the ones that were active for a particular month. So it depends on what you're trying to do and sort of where you're starting. So creating a static cohort is really easy. You can upload a list of patients. You can cut and paste them right into this little box right here and hit confirm, which will then give you what is here in the gray behind a list of patients. When you go to that list just on its own, you can see their date of birth, phone, care manager if they have one, and their next appointment. Or you can apply that cohort, and Molly's going to show us a little bit of that later on, across any of the measures or registries that exist. So the beauty of it is you can identify patients and use that to manage them, but you can also then use it to monitor improvement and see what changes that you've made. So I'm going to hand this over right now to Molly, who's going to talk about some of the tools that are available to help you manage the population.
All right, great. Thank you, Luann. So first up, one of the best ways to manage this population is at that point of care. And if you or your center or your care teams are using the patient visit planning report in CPCI drives, one way you can do this is to look at the specific alerts that your pharmacists or your clinical pharmacists might be interested in. So in this example here, you can see the different medication, diabetes, ASCVD, blood pressure alerts that will fire on the PVP for those patients who meet those criteria. So if they don't have a statin medication, if they don't have an asthma prescription to help control their asthma, you will see those alerts on the PVP. And what that looks like on the next slide, you can see for each patient that is coming in for the day, on the left, you'll be able to see their diagnoses. So in this example, this demo data patient, not real PHI, has diabetes, HIV, and hypertension. And then on the right, you can see those alerts for this patient. So this patient has both an A1C and an LDL that was out of control. And you can see when that date was and what that result was. So like Luann said, if your pharmacists are booking appointments, you can filter to those clinical pharmacists, or you can use those cohorts to filter the PVP and just see those patients that you're focusing on. In addition to the PVP, you also have the care management passport. And you can see those last assessments on the left-hand side. And then on the right, you can see those trends in the numbers. So this patient's BMI is going down, their systolic and diastolic blood pressure is going down a little bit too. And even though that A1C and LDL was elevated, the LDL is going down and that A1C is sort of flattening off. So there is some improvement and some change for this patient. Also on the care management passport, you can see the patient's medications, as well as if you have the referral module in Drives, you can see any open referrals. So this is a great snapshot of a patient if you're a clinical pharmacist seeing a patient for the first time and really want a quick way to get a sense of where this patient was and what trends this patient is seeing. So that's at the point of care. When you look at it from a higher level, a population management level, you can use tools like dashboards and Drives. And this is a hypertension dashboard that I believe is available to everyone in
Yes.
So you can see the breakdown of your hypertensive population. So your number of patients with hypertension, percentage of those patients who are in control, and then breaking it down on the bottom row, you can see patients with controlled hypertension with no anti-hypertension medication, uncontrolled on a monotherapy, and then the percentage of patients with a medication intensification. So this is at a center level. I mean, if you go to the next one, you can see filtered down just to one clinical pharmacist and those patients that that pharmacist is seeing. So you can see now that's only 72 patients with hypertension, the change in that control, the medication on monotherapy, and that medication intensification. So you can use a dashboard like this to compare your general center-wide population compared to those patients who are engaged with your clinical pharmacists.
The other thing that I'll just add on this is if you look at some of the widgets, remember that the widgets are measures that we have. So in your program and your approach, there may be certain things that you want to tackle, and it may be other people that tackle certain things, right? So you've got the undiagnosed population. What do you want to do about those? What type of education might be necessary? And if you diagnose them, then what kind of treatment regimen are you going to start? You may want to look at those patients here, that 50% that have hypertension and no antihypertension med. Like that's a sure win, right? Unless there's somebody who's refusing medication, but you can start to try to understand what those reasons are.
And then below that, you'll be able to see sort of those measures broken down by specific provider. And you can click on those links to see who this patient is. Can I get them back into the center? Can I get them on a hypertension medication and maybe see improvements, or connect them with that pharmacist so they can see improvement in their control? Another way to look at your chronic disease population and your clinical pharmacy engagement is a scorecard. And so this is a very large scorecard that I put together with some examples of measures that you might want to look at. So looking at hypertension, your prevalence, as well as your control for your hypertension population, looking at diabetes prevalence, and then your A1C control for your diabetic population, and then some of your other UDS measures like IVD aspirin use, statin therapy, and then at the very bottom, there's appropriate medications for asthma. So thinking about, like Megan was saying earlier, what populations are most important to you? What measures do you want to track? And then are you looking to track performance improvement? Are you looking to improve your quality numbers for UDS? Or are you looking for that more specific patient information? And again, like anywhere in Drives, you can use that rendering provider filter or that cohort filter to narrow down the results that you're seeing to maybe just your clinical pharmacists or just those cohorts of patients engaged in those services. On that, back to that specific patient level detail, there are a number of different registries available in CPCI Drives and many more registries that you can create for yourself that will help manage and help you track different populations. So here we have a hypertension registry, and you can see each row is a patient who either had a qualifying encounter or is coming up and has an appointment scheduled for the future. In that first row in that green box, sort of starting in the middle, you can see that third most recent blood pressure that patient had was 31/85. And then right to the right of that, you can see just a few days later, they started a statin med. Their second most recent blood pressure was 10/12, and that was 126/85. But their most recent blood pressure was 11/25, and that BP was up to 151/95. And you can see on that date, they did start an ACE-ARB. In the red box, your second most recent blood pressure was 124/72 on 10/27, but that most recent blood pressure was 140/74. And then you can look at that medication. This patient started a statin in September and started an ACE-ARB in September, but the very last column, you can see they ended that in October. So you can use this and these types of registries to look at patients, to track their blood pressure over time, and to see if they are prescribed a medication to help manage it. Other measures you can use to look at your engagement with your clinical pharmacists is this hypertension medication intensification measure. And you can look at this by location or by provider to see if there's any clinical inertia on certain providers or certain care teams who are more or less likely to be prescribing medications for hypertension control. So in the comparison chart on the right, you can see that this is grouped by rendering provider, and the names are blurred out, but you can see that some of those providers are performing higher than average across the center, and some of them are performing lower. So you just might want to talk to those providers to see the differences in their approach with these patients. You can also look at the patient details for this measure to look at specific opportunities. So looking for patients who have an upcoming appointment coming up, but don't have an intensification date or an intensification medication. So looking at the gaps for this list as well. And the other way you can look at this measure is to look at patients who do have that intensification and following up with those patients to see, is that medication working for them? Are they in control of their hypertension now, or is there another sort of treatment or therapy that needs to be added to help them get to control? So we were focusing on hypertension before, but you can also do very similar things with other chronic disease like diabetes. So in this example, you're looking at a dashboard for patients with diabetes, looking at specific cohorts that they've created to track these different diabetic populations, and then breaking down that A1C, whether it's in control, whether it's been tested, or whether it's been out of control. One other thing that you can look at and you can think about using CPCI drives is breaking down these measures by other factors. So here we're looking at the hypertension controlling high blood pressure measure and breaking it down both by race and by ASCVD risk score. So you can see that on the right side, the more than one race category is has a higher control in all of the categories of ASCVD risk besides low. So just thinking about different ways and different methods you can break down your populations and help you understand your performance. You can also look at things like ethnicity, SDOH factors, language, just different aspects of a patient that might impact their ability to get to control for hypertension, diabetes, asthma, any of those chronic conditions that you're working with and engaged with your clinical pharmacist for.
Many of you also, I know, are very active in your patient-centered medical home. And so that may be one way you think about how you use your pharmacist also on working towards those same goals that you've identified for PCMH and who needs care management or extra support and services.
And then finally, from more of an operational standpoint, if clinical pharmacists are booking encounters and have those appointments scheduled, you can use the patient interactions measure and filter to that specific rendering provider to see what types of visits these patients and this provider are seeing each other at, and then that specific detail of who those patients are. So this specific clinical pharmacist has seen 7 patients in May, and you can see on the right that's split between a PharmD visit, a prep visit, a video visit, and a teleprep visit. So if you have specific encounter types for your pharmacist, you can use this measure to help see the impact and the interactions between the two. All right, and now I'll turn it back over to Luann for quality.
Great. So I said earlier that I'd share those results from the study that was done in Ohio. This was the 7 centers, and they followed approximately 1,700 patients. And you can see here their results from March of 2014 to June of 2018. So on the left, we have A1C control. And what you're looking at here is in March, and this is similar to the dashboard for diabetes that we showed, right? In March, everybody had poor A1C control because that was the population that they chose to enroll or look at. And then for each subsequent year, you can see that the number of patients that are not in control goes down. So it went from 100% to 40%. So that's 60% of the patients were able to get their A1C from greater than 9 to less than 9. And the same with blood pressure control. You really see that big drop the first year, even a more significant drop than an A1C. And then they continued to have some ongoing management with them and brought them down even a little lower so that you've got about 79% of the patients in control with their blood pressure. So these are the kind of things that you want to be able to show your leadership for the work that you're doing. And being specific around the population that you're working with is important. Sometimes people get like, oh, it's not big numbers. It doesn't have to be big numbers all the time, right? Because even the small changes will make a difference. And I'm not going to go into the details in this, but I leave it here for you. This is a study that looked at the impact of A1C control, also blood pressure and cholesterol, but what it took to make a difference in the overall cost of those patients. And so they found that a reduction in A1C of 1.25%, scenario two here, had significant cost savings per patient over a 3-year period. Now, one might say a lot of these costs are not happening in your health center, but some of them are. And so this is a little bit about the, as Heather likes to talk about, the dark green dollars and the light green dollars. These may not come back to you specifically unless you're in an ACO, and then it might impact you. But you can see those savings. Some of those savings can be through reduction in hospitalizations. Some of it may also be around if you start billing for your pharmacy services and what actually happens with that money. And that's one of the things that the study looked at was for the centers involved, did the money that was generated from the pharmacy visits, where did it go? Did it go back to the pharmacy program? Did it go back to the general health center? Did it go someplace else? So think about what those savings are. And hopefully this is something that we're going to help you be able to see better. So for those of you who were at our user conference, we are starting to talk about care effectiveness and not just how are you doing on a performance measure, right? Because you want to know about how the program is doing and how your patients are doing. Are they getting the right follow-up? Are their clinical indicators improving? What did it take to get there? And who do you still need to follow up with? So if you think about our immunization management report, which identifies patients who are overdue on their immunizations and don't have an appointment, those are the kind of things that we're going to start to be able to allow you to do in CPCI. So we're going to start out basic with some very basic reporting for a particular population that won't be as refined as I want it to be. But by the end of the year, you will be able to apply your own cohorts like the pharmacy one and be able to see different levels of improvement, right? So was there any improvement? Was there clinically significant improvement? Was there remission? And remember, like remission is getting into the numerator of the denominator. You may have patients who come in with an A1C of 15 and you get them down to 12 or 10, but they're still not going to be in the numerator of the measure, right? But you did a lot of work and the work you did was good to get them there. And that will make a change in that patient's life and how they're able to manage day to day. So the example here that I have is behavioral health, but the same thing will exist for A1C. We're still developing the diabetes part of this, but really looking at change in PHQ. So we're able to get the first one and the most recent one and tell you what that difference is at a patient level, which this is in demo data, or at an aggregate level so that you could look at a particular provider and be able to see how many patients that provider had and what was their change. Were they still in the program or out of the program? And really start to then be able to make decisions about how patients are distributed and the kind of care that you're providing. When we first create this, the diabetes cohort, which will be sort of a predefined population, will be A1C greater than 9 and an encounter in the last year. And we'll be able to show you that change in their clinical criteria for their systolic blood pressure, their PHQ-9, and their A1C. And this is a look at what that looks like, right? So this again is demo data, but you can see that we've got 801 patients and we're looking at their glucose control. So the circle tells you what level of control they have. And the same thing for blood pressure. And I can go down to an individual patient and see that information. And we're building this out, but we'll start to look at things like, are they on insulin or just an oral agent? And then I can also look at that same information for the population, right? And how well, again, is a particular provider, or if they've been seen by a pharmacist, what's their average A1C score, how many patients had a drop of greater than 1.5. So all of those things, and then a 10-point drop in your systolic blood pressure. So things to help you manage the population and get a better sense of how you're doing. And I think we already got this one, sorry. So we had the question about medication adherence that I talked about earlier. And so we are in the process this year of developing some reports that will look at information around when the prescription was issued, written, right? And connecting that to the claims data that we get back from Health First. And so that we'll be able to report on things like unfilled prescriptions and also those where patients are due for a refill or and look at their refill report so that you can see which meds they're due for. So that's really exciting. And I just wanted to share that with you as what's coming and how you can think about using that with your pharmacist, because it will be right in your hands, married to your EHR data. And now I want to hand it over to Chicanes to finish up.
Thank you so much, Luann and Molly and Megan as well from the Chautauqua Center. As always, you deliver. This was a fantastic webinar. I do want to make sure one final question in the chat is addressed. When will the care effectiveness reporting tools be available?
Yeah, so I believe that behavioral health will be the first one out, and then diabetes will follow. I would imagine at the earliest, the end of June, and we'll have a webinar specifically on care effectiveness, and at the latest, end of July. And it will evolve over the next 6 months to have more functionality available and more populations.
Very, very exciting indeed. And thank you again. We are almost at the top of the hour. Please remember to fill out the satisfaction survey. Sophie had kindly posted the link in the chat. We always appreciate your feedback and use that to ensure that we always provide you with the most valuable content and resources during these sessions. I just want to quickly plug the Diabetes and Cardiovascular Disease Prevention and Control Project. Believe it or not, we are in our 3rd year. It will be our 3rd year come July. And we would love to partner with you all on really impacting health outcomes for your patients with diabetes and prediabetes and cardiovascular disease, inclusive of hypertension, undiagnosed hypertension, and high blood cholesterol. Certainly all the tools that have been reviewed today will feature largely during our work together. We always like to emphasize use of the CPCI drives that has such a wealth of information and possibilities in terms of addressing your patients' care gaps and health outcomes. Also reminding you all, this will be a wonderful opportunity to establish partnerships with community-based organizations for patients in need of self-management and prevention programming. So please feel free to reach out to me. I would love to connect with you all, and I will put my email in the chat. We do have a tight deadline in terms of recruitment. We do have a few slots left. So please reach out to me, and I will be sure to put something on the calendar so we can discuss more and discuss how we can synergize with your efforts around your patients' chronic conditions. So thank you all.
Maital, there was one more question around sharing the scorecard designed for measures related to the pharmacy measures. Molly, is the mega scorecard that you had, is that in Chicanes?
It was just for one center, but I can make it available to all centers.
Great, that would be perfect. Thank you.
Sophie, correct me if I'm wrong, but you'll send out the slides and the recording of this, so you guys can take a look at this later on as well and create your own.
Yep, will do.
Perfect.
All
Thank
right.
you, everyone.
Thank you all.
Thank you all. Have a wonderful day. Thank you.